All right, we are good to go. Thank you for joining us today in launching SickKids' second Black History Month and Liberation celebration. And I am so honored to be part of these conversations in such a monumental day in our history. And it is without further ado that I will turn it over, that I will introduce our two MCs for the event, just as we all are having technical difficulties. Just bear with me. Sorry, Labisi, for some reason, the slides are gone. All right, so I'm just going to wing this because I know these two people so well, and I am very honored to continue conversations. Thank you. So many folks have seen this picture, and so I am T. Garnett. My pronouns are they, them. I am the inaugural executive lead and strategic advisor of equity, diversity, and inclusion here at SickKids. I am also the granddaughter and great-granddaughter of John Henry, who was an enslaved man who escaped to Collingwood in 1831. And I am proud of my history, both as a Black person and as a Canadian Black person. On this land I stand, that I do this work to create safety and spaces to really learn how and where we can do better and need better. And I continue to do this work and am part of such critical conversations such as what we have here today. I also would like to take a moment to introduce our first executive student at SickKids. Labisi Odamade is a trained and legal official, graduated from Kent University at United Kingdoms, is a lawyer, was called to the bar in 2017. In 2017, she's currently completing her MBA at McMaster University and continues to support us both within her legal expertise as well as lived reality from our shared places of culture and ethnicity. It is in this role that she continues to support not only Black history and liberation, but is rolling out the first anti-racism policy at SickKids. We are so proud and so honored to learn and work with Labisi every day. And I want to thank Labisi for her continued support and patience in this event and as we continue these conversations. Thank you so much, Labisi. Next, I would like to introduce just an overview of our month. If folks have not had a chance to really register or lean in, please do so. I promise it will not fail to not only educate, but also inform and engage us in these conversations. We don't know what we don't know. And so today we will start by informing our spaces with Black community health and wellness. The theme for Black History Month, ironically, is Black health and wellness. And so it is apropos that we bring these two conversations together on how to support and engage in critical race analysis, anti-Black racism, all in support of Black health and wellness. So today I'm honored to work and with Paul Bailey, the Executive Director of Black Health Alliance, and Shelly Phillip. To start us off will be our MCs. Many folks may know Elena Blackwood. She has been at SickKids for 14 years and has worked in many departments, but I am so familiar with Elena, who is leading the EDI Champions Education and Training Program. Elena has continued to lean in and offer me a safe space to both learning the understanding of SickKids culture while navigating the various challenges that exist within these spaces. She's continued to support me both within her role and also within her identity. And I thank Elena for always being that safe space for me. Elena continues to do this work within solidarity within Linda Nguyen. And Linda has brought into these conversations, both from a East Asian space, but also what a demonstration of solidarity, racial solidarity looks like. Linda has also been at SickKids for many years, 13 years, and continues to lead many conversations. I've been honored to work with Linda both in the EDI champion roles, but also in her positions within ECHO to create these spaces to understand community health and engaging in health and wellness. And so without further ado, I will turn it over to Linda and Elena, who will lead us in this conversation.
Thank you, T. So we would like to start with a land acknowledgement as we get the session going. We would like to begin by acknowledging the land on which SickKids operates. For thousands of years, it has been the traditional land of the Huron-Wendat and Petun First Nations, the Seneca, and most recently, the Mississaugas of the Credit River. Today, Toronto is home to Indigenous peoples from across Turtle Island. SickKids is committed to working toward new relationships that include First Nations, Inuit, and Métis peoples, and is grateful for the opportunity to share this land and caring for children and their families. We're speaking to you today from Treaty 13, the Toronto Purchase, upon which the SickKids campus is built. We recognize this land with an expression of gratitude and appreciation to those whose territory we reside and work on. We honor Indigenous people who have lived and worked on this land historically and presently. I invite you to be mindful and intentional in appreciating where you reside and the rich land in which you work and engage in your practice.
I'd like now to share a prepared respect and trigger statement. So whenever SickKids members gather, we respect all peoples of the world. We will not accept any unwelcoming words, actions, or behaviors against our members. We accord respect to all persons, regardless of age, creed, political affiliation, place of origin, and racialization, including but not limited to people of African descent, Black, Caribbean, South Asian, women, men, First Nations, Métis and Inuit peoples, people of ethno-racial groups, people with disabilities, gays, lesbians, bisexual, transgender, transsexual people, and gender diverse persons, francophones, and all persons whose first language is not English. In our diversity, we will build solidarity in healthcare. So our event provides an open space for the critical and civil exchange of ideas. There may be content that some folks may find offensive and or traumatizing, but we'll aim to forewarn participants about potentially disturbing content and ask that all participants help to create an atmosphere of mutual respect and sensitivity.
So today, for the start of this speaker series for Black History Month, we will be hearing from two panelists, Paul Bailey and Shelly Phillip Laforest. The theme for today's talk is Black Community Health and Wellness. I'd like to introduce Paul Bailey as our first panelist. Paul is a strategist, urban planner, and executive director at the Black Health Alliance. Paul has spent the last decade designing interventions focused on improving outcomes for Black children, youth, and families as it relates to health and well-being, community violence, mental health and addictions, and the social service sector. His work is currently focused on social planning, health equity, and addressing the causes of neighborhood distress and inequality. And with that, it's over to you, Paul.
Good morning, everybody. Want to just first say thank you to T, Labisi, Marta, Linda, and Elena for organizing this event and the invite, and a special shout out to Labisi for all of the work done to organize today's event and supporting me throughout all of that process. Going to jump right in, and for me, what Black History Month or Black Liberation Month means is really an opportunity for us to take a step back, to think, and to organize our actions for kind of the road ahead. It's almost looking back to go forward in the principle of Sankofa. My talk today will be short, and what I wanted to focus on is Black communities and health. So, we did the first acknowledgement, but I'd also just like to acknowledge that Black Health Alliance operates on a sacred land situated upon the traditional territories of the Wendat, Haudenosaunee, the Anishinaabe, and the Mississaugas of the Credit. And also share that, a practice that we do here at Black Health Alliance is we also acknowledge those African ancestors who came here as settlers or margits in generations and generations past, as well as those who came here involuntarily, particularly those who were brought to these lands against their will as a result of the transatlantic slave trade and enslavement. And we pay tribute to these ancestors of African origin and descent. So jumping right into the issue, I like to call this the Black Health Challenge. We know that in Canada, Black populations face significant and disproportionately poor health and well-being outcomes when compared to the general populations. We know that these challenges occur across several social determinants of health. So things like housing, food security, early childhood development, and income security, and that we're among those that are most burdened by significant health inequities as it relates to chronic illness or conditions in mental health. An ever-growing number of studies correlates both these outcomes across the social determinants of chronic illness and mental health, correlate these poor outcomes to experiences with anti-Black racism. So in situating the problem, I wanted to take a few minutes to just introduce the Black Health Alliance and the work that we do. Our mission is to reduce racial disparities in health outcomes and promote health and well-being for people from diverse Black communities across Canada, without focus, obviously, on the social determinants of health and racism. And our vision is that people from diverse Black communities in Canada experience optimal health and well-being. What we currently focus on right now, we're not a service provider. We work a lot in the systems innovation or systems change space, trying to reimagine the systems that we operate in, do a lot of work in health promotion, fundraising, because nobody really funds this kind of work. Championing health equity, which is a fancy way of saying, we are important advocates to get access to the care and services and basic needs that will improve our health, research, knowledge mobilization, and public policy engagement. And we serve really as a platform for convening and capacity building. I wanted to share one example of a project that we do. It's called Pathways to Care. When you look at some of the data and some of the experiences that Black youth face as it relates to mental health distress, one of the jarring stats is that the amount of time on average that Black youth wait for mental health treatment is double the amount that white youth face, so 16 months. Young folks who are of European or white descent face 8 months, so that's 1 school year. For Black children, it's 2 school years. 1 school year is enough, not only 2. And so in response to some of the context that we saw, we developed Pathways to Care, which essentially aims to remove barriers and increase access to mental health and addiction services for Black children, youth, and their families. And so we've done this through thorough engagement of families, youth, and service providers in primarily Southern Ontario. And we're now working with some of those same providers and stakeholders in the space, government and community service partners, to figure out the ways that we can improve the pathways to care for Black children, youth, and their families. So, one outcome there is, we've just been successful in getting the Ontario government to invest into a targeted and very specific program for Black youth mental health in 6 cities across Ontario. And so that work started a few years ago and continues on right now. But jumping back again to the topic at hand, I shared a little bit about the issue, so I won't go over that again. But I wanted to deep dive a little bit into anti-Black racism and the public health crisis that it is. Many folks may not understand the depths of what anti-Black racism is and means. So I wanted to share a bit of a definition. I won't read the definition, but essentially anti-Black racism can manifest on an individual level, person to person. It can manifest as internalized, and it can manifest in systems. And when it manifests in systems like the healthcare system, it means that, while everybody may be free to walk through the doors or go through the doors of a hospital, the experience that people face in that hospital isn't always the same. They don't have equal access to the same treatment sometimes. They don't have treatment in the terms of how people are treated when they're receiving care. We assume that, universal access means that folks can, again, just go through that door. But if we're not taking into account where people live, how people access service, people's comfort or trust with those systems, we're not necessarily understanding exactly how anti-Black racism functions, and then therefore what we need to do to resolve that issue. So Canadian Medical Association, did some research in the early 2010s as it relates to what makes Canadians sick. And from their analysis, they broke it down into 4 different categories. 50% of what accounts for poor health outcomes are your life, so social determinants of health. 10% is the environment, so things like air quality, etc. 25% is access to care, and 15% might be your genetics or biology. The reason why it's important to situate this piece of information is because we know that when we're talking about anti-Black racism in healthcare, we tend to focus on just access to care. Access to care is critical and important, but if you look at the pieces around your life and the environment, that's 60% of your health is based in where you live and your access to resources, essentially. And so our thinking is that if we're going to work together to improve health and well-being outcomes, we need to understand how our health is made up and take action in the appropriate areas. I just also wanted to share a bit of stats. So there are approximately 400,000 Black folks living in Toronto. We know that the population in Canada, but it's true of Ontario as well, is quite young. And we know that the vast majority of Black folks live in urban areas. And a lot of Black folks now, mainly newcomers, are coming from about 125 different countries and are mainly from the continent of Africa. That to say that the Black community is very diverse. As T said in the beginning, folks who are from Canadian descent, folks who are coming from the Caribbean or the continent of Africa, all of which make up the Black population that we're talking about. A little bit about the social determinants of health as it relates to Black population. So we know that Black populations are among those with the highest youth and adult employment. Poverty rates for children in Black families are almost 3 times that of non-racialized families. We know that Black populations make up the greatest percentage of the working poor, and that for families, Black families in Toronto, poverty is generational, meaning that from generation to generation, it stays quite stable. Whereas when you compare that to some other racialized groups, it actually goes down from generation to generation. We know that high percentages of the Black population are concentrated in low and very low income neighborhoods, and that 30% of the Black population, compared to 12% of the total population, faces challenges around food insecurity. And then just quickly on a current health snapshot, we know that diabetes prevalence among Black women from 2001 to 2012 doubled from 6 to 12. That Black women represented 61% of the women in Ontario newly diagnosed with HIV in 2015, that Black folks from East and West African and Caribbean origin have 60% increased risk of psychosis, and that Black populations are at higher risk of diabetes and hypertension. So 2 major risk factors for cardiovascular disease. I threw a whole bunch of stats at you just now, but what's important to understand, again, if we're going back to the conversation around what makes us sick, when we're sharing some of these stats around your life, the point in sharing a lot of these stats around the social determinants is to get folks to understand that what underlines some of these poor health outcomes as it relates to chronic disease and mental illness is actually the social determinants of health. It's things like poverty, early childhood development, housing, and food security. I'm going to share 3 quick maps with you that kind of further illuminate the point around the social determinants of health. So this is a map of the city of Toronto. SickKids would be down, in the middle of the map, somewhere down here. On the top left and right corners, you're seeing the low and very low income parts of the city, and the purple dots represent high percentages of the Black population sense. As you can see, Black populations are heavily concentrated in low and very low income parts of the city. This is a map that's showing diabetes prevalence rates per 100 persons across all age groups. And you can see that the highest rates in the darkest colors are overlapping with a lot of the areas where low and very low income neighborhoods are. The same is true for a topical discussion around COVID. So these maps come from April 2021, and essentially it's showing you the same kinds of patterns. We're looking on the left at COVID hospitalizations and deaths, so highest in the north and northeast parts of the city, and vaccinations are lowest at in the same kinds of areas. And so, what does all that mean? It's important to understand that when it comes to talking about health and talking about social determinants of health and talking about chronic illness and disease, that there are patterns that show up in the places that we live and the lives that people are leading. And I think, like we at the Black Health Alliance, everybody has a responsibility to try and work through to understand the conditions that people are living through, and then figure out what their individual response is, but also the response of organizations are based upon where we sit. And so, our philosophy about where we need to focus is obviously, a large focus on the social determinants of health, that we need to continue to focus on addressing chronic illness and mental health, that, if you understand that the specific ways that Black folks experience the social determinants of health is rooted in anti-Black racism, as I mentioned before, that we have to have a focus on eliminating anti-Black racism and working and building connected communities to do that better. Wanted to share one or two quick stories around how we do this work to work to resolve some of these issues. So early on in the pandemic, there was a call from community organizations for the government to collect race-based data as it relates to COVID infections. And the response at the time from public health officials was that wasn't necessary. So folks advocated. There's been lots of work in the space around why data is needed, how it helps communities to understand the size, scale, and scope of particular problems that are facing, whether it's Black or Indigenous or the racialized communities, et cetera. And we were able to successfully get some of that data to be collected in places like Toronto. And we realized from that data collection that while Black folks make up 9% of Toronto's population, 26% of the cases in early and late 2020, 2021, that was the stat facing Black folks. And so that data allowed us to push for the kinds of plans that would respond more effectively to the specific needs that Black folks were facing. So, these calls for data aren't just data collection for data collection's sake. It's data collection plus action so that we can actually address the issues that are facing communities. You'll probably hear more about this from Lana James on February 16th. Brilliant Lana James around this. There are a whole bunch of thoughts and perspectives around why we should collect data or not collect data and how that should be done. But, for us, we thought it was important to do some of that work and to push that work forward. More specific and granular, an example of the kinds of culturally appropriate or safe interventions that work to address some of the situations that I was mentioning in the data, particularly the pieces around mental health. A quick story is a partnership between CAMH, so Center for Addiction and Mental Health Hospital, and Women's Health in Women's Hands Community Health Center. They work together to develop and expand culturally adapted cognitive behavioral therapy. And they did this by moving the program outside of the hospital and moving it into the community, where folks had more trusted their service providers, and were in an environment where they knew that they were being cared for, because so many of us have negative experiences in clinical spaces, particularly hospitals. And so it was important to do that. And what they were able to do by moving the program outside of the hospital into the community in an environment where folks were better cared for, they were able to move from folks who were kind of being admitted to the emergency departments that at 30%, they were able to move that down to 3% over the course of the pilot that they ran. So, I shared a lot, and I'm going to try and wrap up now. The context that Black folks are living in the city of Toronto, but across Canada are facing is significant. And I think, it's important that everybody working in the healthcare and social services space understand that they have a responsibility to work toward a society where everybody has the opportunity to lead a healthy life. And so I decided to focus my so what, now what, after we share all these problems, on what SickKids can do. And so I think, SickKids is a national and world leader in the health system space. And so I think it should use its voice to ensure and help equitable access to critical services to improve health outcomes for children. I think it's important that collectively we work to prioritize health equity and provide the increased access to the child and family-centered care that's outside of the hospital sometimes and outside the downtown core. And like CAMH partnered with community health centers. I know that SickKids does some of this already, but it's if we're going to work to focus on Black communities, I think this piece is critical. That this piece around culturally safe programming that works to provide services where people are. I think the collection of socio-demographic data to assess and respond to the ways that anti-Black racism manifests in its own walls, SickKids' own walls, is critically important. This obviously needs to be, done through the principles of data governance. But again, you don't sometimes understand fully what you don't measure. The experiences that people have are an important source of data, but other data points help to further illuminate the ways that people are experiencing this, whether this be patients or whether this be staff. We must work to develop strategies that advance policies to eliminate anti-Black racism. And I think, as one of my mentors says, we have a responsibility, all of us, to transform our sick care system. So a system that, waits for people to walk through the door and tries to provide the best service that they can. We have a responsibility to transform our sick care system into a truly healthcare system that prioritizes excellent care and excellent health for all. And in order to build this kind of a system, we need to not just focus on access to care. That's a critical piece, but we also need to be collectively invested in understanding what our neighbors are facing and responding to those critical social determinants of health that I shared a bit earlier. But I'll close there and perhaps turn it back to you, Elena and Linda.
Thank you so much, Paul. Lots of great information in there. And after we hear from Shelly, we will give a summary of the takeaways from the excellent talk. So with that, I'll turn it over to Linda.
Thanks, Elena. So it is my absolute pleasure to introduce our next panelist, Shelly Philip Laforest, who has been a registered nurse for almost 23 years. Originally a diploma-trained nurse, Shelly returned to school to complete her Bachelor of Nursing degree, a Master of Nursing degree, and she's currently enrolled in an interdisciplinary social research PhD program. So as a bedside nurse, Shelly has taken on various roles across the organization, including the OR, burns and plastics unit, general surgery, orthopedics, and otolaryngology. And now she's currently a member of the vascular access team. So Shelly's passions include mentoring, education, and network, and she has held formal educational positions as a clinical instructor, faculty advisor, and professor with several post-secondary institutions. Shelly is also actively involved in community organizations and is a member of the Community Advisory Committee for EPLINK, an epilepsy research program, as a board member of the Epilepsy Ontario, and as a data review committee member for Ontario Brain Institute. She has been a speaker for the Registered Nurses Association of Ontario mentoring session on informal videos for About Kids Health, and is a panelist for an Ontario Brain Institute public talk on data sharing. So in January 2021, Shelly founded and is the executive director of the Ontario Black Nurses Network. This is a nonprofit organization that has been instrumental with strengthening the voices of Black nurses and nursing students in various healthcare platforms. Shelly, I'll hand it over to you.
Okay, thank you very much, Linda, for that introduction. Thank you to everyone for being here. It's such an honor to speak after Paul. How can you go after such an amazing talk? I'm excited to be here. Thank you to the SickKids team for organizing this event. I echo Paul's comments. The BC, great job with keeping us organized and running such a great event. So I'm here as the executive director for the Ontario Black Nurses Network, and I wanted to start a little bit by telling you about our network. So as Linda said, I founded it last year, January, and it was founded with the following mission. It's to grow our community of Black nurses practicing in Ontario, to recognize practice excellence and contributions of our members, and to provide mentorship, learning, and career development opportunities for our members. So our membership has grown exponentially over the course of the year, and I'm privileged to share this journey with our collective of Black nurses and nursing students. We have approximately a 60-40 split of nurses and students, and they are working in a multitude of nursing fields and are from various educational institutions. Also, as we know that Black leaders are greatly underrepresented in healthcare leadership roles, our organization is also launching an initiative this year to do our part to teach and prepare future leaders. Next slide, please. So I wanted to, I'm here as the executive director of Ontario Black Nurses Network. However, I'm also here, as Linda had said, I've worked at SickKids for the majority of my my adult nursing career. And I want to preface this by saying, you know, I continue to learn, I have a willingness to learn, but I'm here as I'm a Black wife, I'm a Black mother, I'm a Black daughter, Black sister, and a Black nurse. I'm definitely not the expert on healthcare organizations, on nursing, or a voice for the entire Black community. And I think Paul would agree with me, that is not what we're doing here today. However, as he was mentioning, discussing anti-Black racism has to also begin within our walls. And with that hat on, as a SickKids nurse, I'd like to share some of my within the walls thoughts about how we can connect to the community and impact the wellness of the Black community outside of our walls too. So coming here today, this slide that's up right now, just wanted you to take a good look at it. And it reminded me of a story of when I was on one of the inpatient units working. There was a young girl that I had met, and she had no parents present. I walked into the room, was taking care of her that day, and her hair was a mess. And you can see the pictures on the side that for some people, Black hair looking like this looks okay and it's fine. But for me, it was a mess. It was matted. It needed taking care of. I asked the little girl, would you like me to braid it for you, comb it for you? And she said, yes. So we prepared, got all of our supplies ready, prepared to wash it and get things ready. And of course, to braid it, I need a comb. So I went to find a comb in our clean supply rooms, and the only comb that was available and may still be on our units is the small comb up in the top right. That comb, for those of us who know, would not be able to comb her hair, but that's all we had available. I went home that day and thankfully was back again with her the next day. And I brought from my house a wide tooth comb, the one that you can see on the bottom there. Also some shampoo that was designed specially for natural Black hair, and washed that child's hair, combed that child's hair, and braided her hair. The appreciation from that child that day was beyond words. And that's all stemming from me knowing what she needed and knowing that she needed that basic care and how to provide that care for her. So next slide. So as I'm so thankful I went after Paul. I did get, you know, I appreciated how he showed the impact that the healthcare system has on the Black community. You know, talking about the health of our population, you know, the prevalence of diabetes, the prevalence of cardiovascular disease, increased risk of psychosis for some populations. But we know that research shows that better health outcomes are direct results of the care providers reflecting the populations that you're serving. So this, I think about the term interconnectedness. So our community needs to connect with our healthcare system. And from that, we will get better health outcomes. People will feel, and research shows this, people feel higher levels of trust for their care providers if they feel there's an understanding without having to explain. Like the child from my story, she didn't have to explain that her hair needed caring for. She didn't have to justify why her hair needed caring for, and she didn't have to ask. She just needed someone to be able to understand and provide basic human care. And that will definitely, we know that holistic care is part of what we need to do to help our patient populations. And connections with the community can exist and should exist, because how else will we know how to treat and care for the Black community if we're not aware of what's happening in the Black community? Paul did touch on some of the stats about what our environment looks like. You know, in Toronto, Ontario having, you know, more than half of the total Black population in Canada. And diving further, when we think about where we're located, Toronto has the largest Black population in the country, and we're a younger population. This gives many organizations and the individuals who are part of those organizations a chance to reflect on, what does your workforce look like? I challenge all of you who are in positions in a healthcare organization. Think about, what does your healthcare organization workforce look like? Does it look like the patients that are, or clients that are walking through those doors? As Paul said, the experience walking through the door can be different for all involved. Next slide, please. So with my hat on, looking at it from the inside out, and, you know, great compliment with Paul looking at it from the outside in, I think about, how can healthcare organizations do better? First steps are good steps, and they're better than no steps at all. So I thought about how to break this down to think about, what can organizations do? What can we do to make sure that people are feeling listened to? And I think it starts with, I have 3 pillars here. I'm going to talk about each one of them. But the first one, I think, is really important to learn. The second one is to listen, and then to engage. So learning, how do we know? And when I say we as the healthcare organization, and I recognize, as I said, my intersectionality, wearing all these different hats as a Black nurse working in these organizations. But I think it's really important, and I'm continuing to learn as well. Where did it all begin? Why is there a hesitancy within the Black community? Why may there be the trust, a mistrust? Why is the care not meeting the needs of the community? And the picture that's up there, if you're, I'm going to get a little bit into, if you're familiar with that picture, but we have to look back, and definitely thinking about before the ending of slavery. And this is information from the CDC if you're interested in following up. But racism was used to justify the African slave trade. There were many arguments that African men were uniquely fit for enslavement due to their physical strength and simple minds. There were arguments that slaves possessed primitive nervous systems and did not experience pain as white people did. And definitely there were also thoughts that if a slave ran away, they obviously were suffering from mental illness. So scientists also believe the brains of Black people were under-evolved, and they also believe that their genitals were overdeveloped, which meant that, of course, they had insatiable sexual appetites and made Black people more prone to catching sexually transmitted infections. This is the history. This is stuff that's happened. And this was also the impetus for the picture, which was the Tuskegee experiment. So I'm going to give a little bit of history about the Tuskegee experiment. It was originally called the Tuskegee Study of Untreated Syphilis in the Negro Male. So it started in 1932 and renamed Tuskegee experiment. Originally, there were 600 Black men, with 2/3 of them had syphilis and 1/3 did not, and they were considered the control group. And there wasn't any informed consent. And you think about, when you're working in healthcare, we hope that everybody who was involved in any kind of experiment, and we call it research, is properly informed. We have many checks and balances now to make sure that this happens, but at that time, there weren't. No informed consent was collected. Compensation was promised in terms of they were offered meals and free basic health care. And if they died, their costs would be covered. And participants were told that they were being treated, but they were not being treated. And actually 10 years later, about 10 years later, there were there was treatment for syphilis, but it wasn't, and it was becoming available, but it wasn't offered to the participants in the studies. So we think about these histories and why there might be that hesitancy, why there might be that mistrust. And unfortunately, or fortunately, there is this belief that the healthcare worker, and I wholeheartedly feel this as a healthcare practitioner, that people do think that you're the expert. And so there can be times where authority isn't questioned. What you say isn't questioned. What the physician might tell you, the nurse might tell you, it's never questioned. And it can lead to changes or differences in care. There's also some historical context. As I said, I keep learning as we go along as well. And finding that there were some medical colleges that used to use mainly Black bodies for dissection when dissection was illegal. So the, there's a book by Blakely and Harrington called Bones in the Basement, where they're unearthing bones and they're discovering that the cadavers that were used were mainly Black bodies. And again, due to preconceived thoughts that these bodies were the ones that you can use, and no consent is needed. And so if you think about those pieces, and even just relating it to the trauma that we're witnessing happening with our Indigenous population as they're unearthing graves, that there are things that are happening within the Black community. And I think that understanding moments of racial trauma that are the reasons why they've led to the hesitancy. So are we judging because we know, or that we don't know, or we've never experienced? The other pillar that I wanted to talk about is we have to learn, for sure. We've got to know the history and then have to listen. So what's being said and unsaid about the Black community in the healthcare system? As I mentioned, the populations of our healthcare providers do not match the populations of our patients. I had done some searches before for one of my papers, that many senior leadership positions in healthcare are not held by visible minorities in Canada. Governing boards of our healthcare institutions, they lack diversity as well. So we know that these have come about a lot of times through access to education, and opportunities for advancement weren't available. However, there are pervasive concepts that still persist. There is a concept of affinity bias. And for those of you who don't know what that is, affinity bias is there's a feeling of comfort people have for those who look like them. So if we put that into a hiring context, there's research that shows that if you had to choose between two candidates, you would tend to go with the one that has more similarities with you. And a lot of times race, skin color makes a big difference as well. So feeling that comfort is sort of what will help to continue these concepts to be present in our environments. And it definitely sets a glass ceiling, or one of my colleagues the other day, she called it the black ceiling. And it can make it very difficult to get positions of influence or to progress to tables where your voices, the Black community voices, can be heard or changes can be made. Personally speaking, many people have asked me, why do I keep going to school? As Linda kept telling you, I keep going back to school, and it must be because I want to get a better position. I usually respond, it's because I have to. I have to do that to at least get to the ceiling and hopefully climb over or around it. And also to set that example, and to also use the privilege that is afforded to me by having these letters to get to the tables and impact and influence. So what is also being said? How are we also showing the Black individual, the Black community, that they're important to the healthcare system? It begins with also teaching them, teaching the care providers how to take care of the people they may interact with. There are these preconceptions, as I've mentioned before, about tougher skin and tougher physiques, which make great experiments, it turned out. But we also think about some accepted norms that are actually not help, but are embedded, that guide treatments and care in our educational system. And as someone who is in academia, I think about the educational system as well. Our textbooks and our learning materials do not reflect the Black community. There are some great initiatives that are coming about, and if anyone is familiar, the picture I put in the middle, I wanted to show the illustration of a viral of a Black fetus, has been going viral. There is I want to give credit to Chidebere Ibe. He's a Nigerian self-taught medical illustrator who's going to school to study to be a pediatric neurosurgeon. In 2020, started drawing pictures, which actually had Black people represented. He's starting to figure out ways to weave Black figures and representations into our narratives. So if you, again, challenge you to go back and look at our textbooks. I pulled a couple of my older ones out as well, and think about the pictures that we're seeing. So if we can't see ourselves in that learning, if our care providers aren't seeing us in that learning, then how do we expect it to translate into the care that can be provided when they are actually accessing the system? So I think back to the comb too. What's being said with the comb, with that only being the only comb that's available? What's being said is that your hair doesn't fit our standard of what should be combed, right? Your hair should fit what we think matters, and make it work. So this is what we have available, make it work. So we have to learn to listen. Those are the pieces that we hope by these changes that we keep listening. And then lastly, the final pillar I think about is we need to engage. And so how else are we going to engage with our Black community if we don't actually engage with our Black community? So taking steps that you have to take steps that appear progressive, that not appear, but are progressive and don't appear performative. Unfortunately, and I had coined the phrase and I've told a few people, I said, the Black communities had to sit back the past few years during the Great Discovery, I call it. And the Great Discovery, to explain it a little bit, is unfortunately, due to a tragic event, people started to realize and look around and say, wait a second, there's Black people here. Wait a second, there are Black people that are going through things. They're realizing the challenges. They're realizing the barriers for the Black community when we, as the Black community, have lived it for our entire lives. So it's important for organizations and individuals who participate within those organizations. They have to make meaningful, authentic connections that are long-lasting and sustainable. As I said, not performative. And I think that begins with putting the faces forward that elicit trust. I put a few things like, our Black Nurses Network, and I'll speak a little bit more about it in the next slide, but just diversifying the hiring, making sure that, as I said, that you are reflective of the environment. Your workforce is reflective of the environment that you're in. And I think that brings about sitting comfortably in the uncomfortable is needed. You need to understand and you need to learn, listen, and engage. Next slide, please. So as I said, I've been a nurse at SickKids in different capacities for my adult professional life. We used to joke about all roads lead back to SickKids. I have been there and love working there. And I think about how SickKids doing this right now. How has SickKids started the path forward? As Paul said, there are things that we all need to do. So it's not just SickKids, we all need to do it. But whether you have lived, if you've never lived noticing race, it would be hard to see what the problem has been. So at SickKids, we know the Black healthcare provider population is relatively low. However, the hospital is making noticeable changes. They've implemented things like this amazing speaker series. They've implemented other ways to showcase Black people throughout the institution. They've implemented an EDI office and put in, and as I said, I can speak from history from having been there for decades. They've implemented an executive lead and strategic advisor in the C-suite. Having that voice at that level is amazing. They've also implemented, we have a Black Experiences in Healthcare Working Group, and that's bringing together a lot of people across the institution. So SickKids is also collaborating with OBNN, our network, and Black North Initiative with the Black Health Alliance with Paul. And so they're showing that these are not performative actions, they're sustainable and significant ones. And also I want to give credit to Paul has said about CAMH recognizing what they need to do in order to help improve health outcomes for their populations. Next slide. So I'd like to thank you. I think that, you know, it's the Black community and the healthcare system are so intertwined. And when it's working eloquently, we definitely can improve the health outcomes and lives of the population. Listening, learning, and engaging, as I said, are integral to making authentic changes. Let's not let this be the let's not let this be where the conversations end. Let it be, as Paul said, the so what, now what, and let this help us move things forward. So thank you very much for this opportunity. I'm really pleased to be here.
Thank you so much, Shelly. Two amazing presentations and lots of great questions coming in. So we're just going to touch on the takeaways before we have time for one or two questions. And just to remind everyone, this is recorded. We will be sharing the recording with the Q&A, as well as the slides in PDF format, and we will be providing answers to unanswered questions on our SickKids website. So the first takeaways for Paul's presentation: 3 points to make. Black populations in Canada face significant and disproportionately poorer health and well-being outcomes than the general population, and as he said, due to anti-Black racism. Secondly, Black communities have been working to drive improved health outcomes for quite some time. This is not new information. It's just coming to light on a grander scale and due to, you know, recent events, global scale, national scale. And 3, SickKids has a responsibility to work with Black communities to help ensure equitable access to critical services and improve outcomes for children. And there have been some questions in the chat about that. And Linda, you can summarize some takeaways you had from Shelly's presentation.
Thank you. So key takeaways from Shelly's presentation. Thank you so much, Shelly. She really points to how critically important it is that healthcare providers reflect the populations that they serve in order to achieve better health outcomes. Critical to foster collaborative partnerships with community. It's such a vital component to this work. And lastly, as an organization, how can we learn to do better? And Shelly nicely highlights 3 critical important pillars. The first being learning and really getting to understand the historical context. Listening, thinking about what is being said or what is left unsaid. And lastly, engaging who should be involved or who is not involved, and really thinking about why. So now we want to open it up for some discussions with the last few minutes we have left.
Yes, so just keeping an eye on time and posing this question. It might be for Paul, but absolutely open to either of you to answer. In the Q&A, we have great presentations. Thank you. Glad that Paul highlighted the importance of sociodemographic data collection in identifying health disparities and improving care. We've begun to roll out data collection initiative here at SickKids. It's still early. We see little data from Black patients and families, however. So we know that we need to build trust, plan on engaging with the community to get their perspective. Wondering if you have other suggestions based on your experience.
So really, I think my answer to that would be, there are several questions in the chat around data. And so to that specific piece around, let me rephrase. I think a couple of things need to happen around data collection. One, data collection needs to happen for a purpose, right? It's not just data collection for data collection's sake. Collecting data to really understand the size and scale and scope of racial disparities and health outcomes. And so that's the purpose. I think it needs to be governed by principles. And so Black leaders in Toronto have developed, folks can Google EGAP, engagement, governance, access, and protection. Principles that govern or can start to govern the way that we collect data. Two quick other things is, there's a question there around like the comfortability of folks collecting data. And I think, this work has been happening in the sector for quite some time. There's an initiative that was developed under the leadership of Camille Orridge called We Ask Because We Care. the former TC Lynn. And it's critically important to just, I think, look to the work that has already happened. Part of the conversation here is often that clinicians feel uncomfortable asking. And I think sometimes folks need to get out of the way in order to make the space for the kinds of work that needs to happen to improve health outcomes. Perhaps I'll leave it there and then type some of the rest of the pieces there in the chat.
Great, thank you. Linda, was there another question you wanted to pose?
Do we have time for one more question? T. Labisi?
Yes, just one more.
I would say yes. I think folks have heard enough from me in the last 10 months. I'd rather hear from Paul and Shelly in this last couple minutes, if that's okay.
Okay, great. So I'll ask, one audience member had agreed that SickKids really does need to collect social data, social determinants data, and perhaps more routinely as clinical history is collected from patients. And so this individual noted that oftentimes they find clinicians feel uncomfortable collecting this kind of data. And so the question is, how can we best train and educate SickKids staff to collect this data efficiently and safely? Or is this data best left to discrete research projects governed by an ethics board?
Yeah, I can answer that as best as I can. I think that I understand what it could feel like trying to collect the data at the base level, the grassroots level. And I think that that's where we need to, as an organization, harness the power and the experience that we have within the institution. I think we've got great clinicians and sometimes, as I said, if your care provider resembles you, people do feel a bit more comfortable sharing and providing that information. However, as Paul pointed out, you also need to show the purpose. What is the reason? Is the reason because we just want to know, we're curious to know? Because when we are doing it just for that reason, we are actually re-traumatizing a population, right? So we have to be authentic with how we're collecting it, what we're collecting it for, being transparent. So I think, yes, there is a point with the discreteness to ensure people's privacy and confidentiality, but I think we also need to show that, as he was saying, we need to care and we need to show that it's authentic. I would strongly suggest, and I think there are opportunities for our network to talk with SickKids a little bit more, as we do have members who are SickKids clinicians, and maybe it's building from there with the faces that actually resemble the patient populations to try to gather that information. I think I just think about a part with a patient one time. They felt more comfortable when I was helping them, and it felt like help for them, that they said, because I guess I looked like them too. So we need to, as I said, just harness that power, harness the experience that we have within our walls to be able to better serve and collect.
Thank you so much. We could continue this conversation easily for many more minutes and hours, but we want to be respectful of your time and everyone's time listening in. So thank you to Shelly, thank you to Paul for putting together two fantastic presentations. I'm definitely going to rewatch this again because there's lots of great information there. Thank you to everyone who has tuned in today, and to kick off this speaker series for Black History and Liberation Month. And with that, I will throw it over to T to close out.
Excellent. Thank you so much, Elena. And I just want to thank everyone else just one more time for this amazing conversation, for such a powerful launch to Black History and Liberation Month, where all of us will leaning in to understand what a healthy community looks like. And in the name of Bell Hooks, a healthy community supports you in being distinct from and included with those around you. So as we continue the conversations, let us create the spaces to invite others to lean in and sit at the table with us. So I want to thank you all, bid adieu, and I will see you next week at 9 o'clock for the grand round. Thank you so much. Thank you, Elena and Linda. Thank you, Labisi. Thank you, Paul and Shelly. Much respect and love to all.
Thank you.
Thank you.